Hopkins CFAR meeting, which is on Friday, September 15th, so next week, and includes the Frank Polk lecture from Wafa El-Sadr, which I'm sure will be fantastic. The registration link is at the bottom of this slide. Excuse me, and maybe we can also put that in the chat at some point. Oh yeah, and I also just did want to mention, I mentioned this at the beginning, but for anyone who's joined since then, the CME phone number changed to text in your participation. Laura put that in the chat. We'll probably put it again in the chat a little bit later for people who join as the morning goes on. But also, please, you can direct message Laura if you are having trouble with that. So any other, just since I know this is a forum where sometimes people make little announcements, anyone else with anything they wanted to just call people's attention to for the next week or so? I'll do the requisite Zoom pause. Okay, great. So let's get started. So first, I'll do a little bit of discussion of some of the aspirational things that were covered at IAS. So IAS 2023 was in Brisbane, or for me was in Baltimore. One of the great residua of COVID is the availability of completely virtual participation in meetings for when 24 hours of travel is not on the table. But I heard from people who went that it was lovely. Hopefully some of you had a chance to go. So I'll talk about some of the aspirational studies that were presented, and then some more practical clinical studies that were presented, and we'll do the aspirational first. So there was a plenary talk from Dr. Williams on broadly neutralizing antibodies generation and vaccine development, and he did present the results of a recent vaccine trial, HVTN 133. So this is a structural model of GP120 and GP41, which are the components of the sort of that little, like on all those coronavirus pictures there, where there's a little red spike, that's the HIV version of that. And depicted on this diagram are the regions that are targeted for neutralizing antibodies. So as we all know from SARS-CoV-2, a neutralizing antibody is one that binds to a virus particle and prevents it from entering a cell, and therefore prevents infection. In HIV sort of speak, when we talk about broadly neutralizing antibodies, we're talking about ones that can neutralize across many different clades of HIV so that they could be used in a global effort to stop the spread of HIV. So in this particular study, they were interested in broadly neutralizing antibodies that target this region called the membrane proximal external region, or MPER, which just means it's the part that's closest to the viral membrane that is right at the bottom of that stalk. And so the way that they developed this vaccine was using a peptide liposome. So these are little liposomal, little like fat globules that they stuck the proximal MPER into, and then use that as their vaccine. And their plan was to administer this with several injections over the course of a study in healthy participants. And their goal here is to take a B cell that's known as the unmutated ancestor, so a naive B cell, and educate it through multiple stages, where it goes to early intermediate, where it can neutralize some HIV, but not many, and then late intermediate, where it can neutralize many different types of HIV, and then finally to this holy grail or panacea of a broadly neutralizing antibody that you can induce in the body, and then have the body producing this antibody that would protect against multiple different types of HIV. So the trial structure here was multiple visits. It was 24 healthy participants who received 2 doses of the peptide liposome and 4 who received placebo. The trial was unfortunately halted due to an apparent anaphylaxis event to the little liposomal fat globules. So they are now reformulating that to something that would be less likely to induce an allergic event. But they analyzed those individuals who had gone through any of the injections, which really was only a few of the injections. So the good news is that despite the fact that the trial didn't get anywhere near where they planned in terms of number of immunizations, they did induce a polyclonal, meaning multiple different types of neutralizing antibody responses in participants. They were able to clone out one specific broadly neutralizing antibody and find all the different stages of development, proving that that vaccine strategy had taken that early naive B cell, brought it through the stages of development closer to this broadly neutralizing antibody. And that is very promising to have seen that be induced by this vaccine. They found that binding to lipids, so the actual lipid components of the liposome, correlated with the neutralization. So that's a nice clue to how these antibodies may work, especially in that membrane proximal region. And they thought that the fact that the antibodies were not, have sufficient breadth to be truly broadly neutralizing was due to insufficient affinity maturation. And what that means is the more times you see it, the more mature the antibody gets, and hopefully the more effective it would be. And their hypothesis is that possibly if they were able to have given all of the injections, they would have achieved better results. So the vaccine outlook, I would say, is still quite guarded. This is promising, and probably more promising than things have been in the past. It was just 20 individuals who received this vaccine, and the allergic event was clearly not optimal, but definitely a strategy that can move forward. So a couple of questions that remain: how many doses would it take to achieve full maturation of these antibody responses? Would everybody be able to achieve them? And then how long would you maintain them, which has become another issue with SARS-CoV-2, where we see the waning of antibody responses over time. So with those caveats, that's some progress, I think, in the vaccine field, and we'll stay tuned to see what happens next with that. So other sort of aspirational things that were presented, there was another case report of a potential long-term remission or cure. This is a little bit in contrast to the other ones. So the 5 reported patients here, with 4 of them identified by their names because they have come forward and desire to be recognized by their names, have all had CCR5 delta 32 bone marrow transplantation. So where their new CD4 cells are inherently resistant to infection with R5 virus. The case report that was presented at IAS 2023 is actually from an individual who received a non-delta 32 bone marrow. And so that is probably most similar to the prior Boston patients, who were individuals who had not received this, protective marrow transplantation, and who rebounded at 12 and 31 weeks after interruption of ART, although prior to their interruption, they had no evidence of HIV in any of their tissues. And this is in contrast, of course, to people who've not had any transplantation or chemotherapy, who generally rebound much more quickly. But the question is how long, or to what degree, do these treatments need to eliminate the reservoir in order to give anything similar to a sustained remission, which is ultimately the goal. So this was an individual, it's a Caucasian male diagnosed in the 90s, started on ART in 2005 with continuous viral suppression. In 2018, he underwent chemotherapy followed by an unrelated allogeneic hematopoietic stem cell transplant in 2018 for biphenotypic sarcoma, which is a rare tumor. The donor was a 9 out of 10 match and was CCR5 wild type, as I've mentioned. So he had full chimerism at 1 month, meaning like the graft cells took over fully. And he did develop acute hepatic graft versus host disease, which was treated with a corticosteroid and a calcineurin inhibitor, and then got chronic hepatitis from graft versus host disease at 8 months post-transplant, and was treated actually with ruxolitinib, which is a JAK-STAT inhibitor that blocks cytokine signaling. So he had a decrease in the immune responses with loss of HIV-specific antibodies and no significant T-cell responses, despite the detection of T-cell responses to other viruses like CMV. And this we use as an index of, even if we can't measure HIV, if the immune system can see it, it means it's still there. And the fact that these were declining over time suggests that that reservoir was contracting. The cells were still susceptible to infection, and there was no replication competent virus that was isolated after the stem cell transplant. So this patient had multiple immunosuppressants for the repeated GVHD episodes, including all of the ones listed here. And so the questions that sort of arise out of this case is, here again, is graft versus host assisting in the clearance of the reservoir, with the graft cells actually attacking tissue-based cells that might actually still harbor HIV and keeping them in check? And there's some unclear implications in terms of transplantation matching. And the patient did, during the course of this period of time that he went off therapy with no detectable rebound, have 2 episodes of use of on-demand PrEP. So this is much more common in Europe than in the United States, where it's not part of our guidelines, but where you take several doses of Truvada or Descovy around the time of a high-risk sexual encounter. And I think, this, in combination with the fact that, the Berlin patient was on PrEP for years before he passed away, sort of puts a fine point on the question of what a cure really means. and also sort of circles back to the beginning, which is that ultimately, as with Hep C, a vaccine is really essential in order to truly provide protection moving forward, even if we were actually able to eliminate HIV. I'll just mention briefly, but I won't go into it, that there was a very interesting study on children with perinatal infection and sustained virologic control. If you want to talk about that, I'm happy to, but I think a little bit too esoteric for this conference. And I'll just mention one other thing, because it is rolling out into a clinical trial, which is, on the cure side, we've heard lots about shock and kill. So turn on HIV that's latent and try to eliminate it. One of the other more recent approaches has been to try to find ways to either cause the reservoir to die on its own or just to remain permanently silent. Presented at this meeting were a couple of studies suggesting that inhibiting pro-survival signals, so signals that keep T cells alive for a long period of time, may deplete the reservoir. This is not surprising in terms of, obviously, a cell that's going to stay around as a reservoir has to stay alive. But there is apparently, in at least some of the reservoir cells, an overexpression of apoptosis inhibitors. Apoptosis is a non-inflammatory cell death. And so there are agents that block these pro-survival signals and lead to cell death. They're mostly clinically used in things like CLL, where you have chronic lymphocytic leukemia, where you have excessive survival of B cells. So presented at this meeting was a mouse study that used one of these BCL2 inhibitors, also combined it with another pro-survival protein inhibitor, MCL2 inhibitor, and showed that if they did this, they sort of reduced the reservoir based on time to rebound. And this is being moved forward from mice into humans in the phase 1 AMBER study, which will be done in Europe to assess venetoclax's safety and impact on reservoir measures. So just to sort of conclude this sort of rapid tour of the sort of track A basic science types of sessions, some promising maturation in the vaccine studies, maybe. Another example of durable control or cure in the setting of a hematopoietic stem cell transplant. And we're continuing to try to find ways to assault the latent reservoir, hoping to find a chink in that armor. So I'll just pause there, and if anybody wants to either put something in the chat or has any questions about those studies. All right, I will keep on rolling. So in terms of practice-changing findings, presented at this meeting and also published simultaneously in the New England Journal of Medicine were the results from the REPRIEVE trial. So this was a study that patients from Bartlett were enrolled in as part of our participation through the ACTG, where individuals were randomized to either receive pitavastatin or placebo. For individuals with moderate to low cardiovascular risk were assigned to receive either receive a statin or not, with the primary outcome being major adverse cardiovascular events. This trial enrolled 8,000 people. It was an international trial, probably the largest of its type done in people living with HIV. And overall, the findings were pretty significant, that it was stopped early, that there was a significant reduction in major adverse cardiovascular events in those who were treated with pitavastatin, so about a 35% reduction. I'm not going to spend a lot of time on this because we will devote a full session to understanding this paper and thinking about how it applies to our patients. I've already had a few patient encounters where we've discussed this trial, and I'll be very interested to see what Todd's thoughts are. In terms of major adverse events associated with the use of pitavastatin, there is this signal that statin use is associated with a higher rate of incident diabetes, and that was observed in this trial. But overall, it was generally well tolerated. So please stay tuned and come back on the 6th to hear Dr. Brown talk about it. And and Charlie is noting that we enrolled 50 participants here, which is really a fantastic job on the part of all the clinicians. And actually, I do think the guidelines panel is having a discussion of how to handle this in the upcoming months, but I think this is a potentially practice-changing study. So more on that later. And then I'll talk a little bit about some treatment initiation studies. So first, there was a study presented by Jürgen Rockstra from Germany, sponsored by Merck, looking at doravirine islatravir compared to bictegravir FTC-TAF as an initial HIV treatment regimen, and they presented their 48-week results from this phase 3 trial. So prior studies have evaluated the use of islatravir in switch strategies, and this phase 3 dual therapy of doravirine and islatravir was designed to test treatment initiation. As many of you will remember, islatravir is a novel nucleoside inhibitor that is a strand transfer inhibitor, not just incorporating into the strand, but has other mechanisms of action. It was generated a lot of excitement a couple of years ago because of its very favorable pharmacokinetic characteristics, which made us envision it as potentially a once every 2 week or once every month oral agent for things including both PrEP and treatment. However, its development was halted based on the finding of a lymphocyte depletion in individuals who were receiving doses of islatravir that were at certain levels or higher. So this is sort of the renaissance of this agent. And in general, I think the overall message is that it's going to be used at lower doses to try to avoid some of these lymphocyte depletion side effects, and probably will not have any of those benefits that we were super excited about in terms of the duration of effective therapy. So this, though, is looking at it in comparison to really pretty much the standard regimen that's used in the United States of BIC-F-TAF. Study population was people with HIV greater than 18, treatment naive, no hepatitis B, and no resistance to agents included in the regimens. Individuals were randomized 1-to-1 to bictegravir F-TAF or plus placebo, or doravirine islatravir plus placebo, because the pills were too different for it to be considered blinded otherwise. And the primary endpoint was HIV RNA less than 50 at week 48 with a non-inferiority margin of 10%. And up here on the right, I've just put the figure showing the diversity of enrollment across multiple continents with really good representation from a lot of different populations. So characteristics of the study participants, about a quarter were female. Their median age was less than 35, as it is for most treatment initiation trials. 57% of them were white, and the remainder were distributed across other race and ethnicity groups. 18 to 20% had an HIV RNA of greater than 100,000 at enrollment. And they actually had a sentinel group where they did the first 60 participants at less than 100,000, confirmed safety, and then opened up to enrolling more individuals with high viral loads. And the baseline CD4 median was 360, with 20% of the individuals at less than 200. So overall, of treatment trials, it's not one of the ones where we have 0 people in some of these groups of higher viral load, low CD4, and relatively good representation. 597 individuals were randomized and treated, and with a couple of discontinuations, so about 269, 268 in the 2 groups at their week 48 analysis point. So what did they find? It was not inferior by the week 48 FDA snapshot analysis. There were virologic failure in 5 individuals, 4 in the BIC-F-TAF arm, in which there was no resistance detected, and 1 in the doravirine islatravir arm, which did have treatment emergent resistance. The treatment failure case in the doravirine islatravir arm had an initial viral load of 1.2 million, had low detectable drug levels at points prior to the protocol-defined definition of failure, indicating incomplete adherence. And then at the time point where full virologic failure was adjudicated and resistance was detected, there was no detectable doravirine islatravir in the system. So definitely at least known to has a risk for resistance, and we'll get into that a little bit more. Not clear that it's any greater than for other regimens. So what about that lymphocyte problem? 5% of individuals required discontinuation due to lymphocyte counts dropping in this pretty strict framework, I think, designed really to preserve to make sure that this adverse effect was not happening. 2% of individuals in the BIC-F-TAF arm required that for the same reason. There was a difference in CD4 gains. I believe the median gain was like 182 cells in the islatravir containing arm and 230 cells in the bictegravir containing arm. So a difference in CD4 gains that may be related to this lymphocytic toxicity. So, and then I think the one other thing, the question that's always in the air about these is when you're looking at alternative agents. Like, why would you reach for doravirine and islatravir as your treatment initiation option? I think what was the weight gain with this novel regimen? And the weight gain was actually exactly the same. So about 3.45 kilograms in the doravirine islatravir arm and 3.3 in the BIC-F-TAF arm, with no difference between the two. So they're now taking islatravir into a phase 3 study at a reduced dose, in part, I think, to try to get rid of any residual lymphocyte depletion effects. And then I guess the question for all of us is just how this will fit into our treatment armamentarium. I don't think it's going to give us a weight advantage. Looking at the preliminary studies on islatravir for renal pharmacokinetics, there was a clinical trial looking at dosing in patients with severe renal impairment, and it is at least partially renally handled. So I have to be honest, I'm not sure how this will fit into the overall structure of where we're still looking for alternative agents. But in the same way, I actually didn't think I was going to use doravirine that much when it came out, and I have actually found it to have a nice use in my practice. So I know that Charlie and Ethel are on. I don't know if they had any other thoughts or comments on this, on islatravir and its development, but the co-formulation is a tiny pill. Yeah.
Eileen, I don't know if Ethel wants to add to this, but Eileen, I just stuck something in the chat that it will be the smallest of all of the complete co-formulated regimens. It's only 100 milligrams plus 0.25 milligrams of islatravir. So that was one of the advantages of islatravir for long-acting formulations, is it is so potent. Yeah. And the dose is so small, you can cram a lot into a formulation, either an implant or an injection, although it's unclear if we're ever going to be able to benefit from that.
Yeah, thank you for that. So we'll see. And it's good to see it back in the mix, as it was, although maybe not with all the things we hoped that it would do. So now I'll move on to doravirine resistance. There was a poster from Chloe Orkin, where they were, to Joyce's question about whether islatravir will be available on its own. I don't know. I mean, I think that's a good question, because initially the development was somewhat, the question was, what will it be paired with because of its unique characteristics? Now that it's been developed as a once daily, in theory, it could be, but I'm not sure. So doravirine resistance update. So the presented analysis in this poster was using the treatment naive studies of doravirine. This is drive forward and drive ahead. Drive forward compared doravirine to darunavir ritonavir plus 2 NRTIs, and drive ahead compared doravirine to efavirenz plus 2 NRTIs. And in both cases, there was an exclusion of baseline resistance mutations. So these mutations would be emergent on treatment. They evaluated through week 192, which includes 2 sort of periods of the study, one of which there's randomization and then an open label extension for individuals who wanted to continue after week 96. The protocol defined virologic failure occurred in 83 of 747 participants, or 11%, through week 192. And 34 of the participants met criteria for resistance testing. So who didn't meet criteria for resistance testing? Those whose viral loads were less than 400. Of 29 individuals in that protocol defined virologic failure were between 20 and 500 for their viral load, and 9 of them resuppressed on the initial regimen, and so did not have resistance testing done. But of the 34 participants who had resistance testing, 10 had doravirine resistance mutations, and 7 of 10 of those occurred within the first 52 weeks of treatment, so within the first year. So overall incidence rate of doravirine resistance was low at 1.3%, and mostly in the first year of treatment. And the major selected, not muttons, but were mushins, I don't know what that word is, but mutations were doravirine V106A or M and an F227CL or R. And the NRTI mutations, which emerged at a rate of 0.9%, so a little bit lower than the doravirine ones, were M184VI and K65R. And then just to add to this, since I just don't want this to be considered as an exclusive list of doravirine-associated mutations, but there are Y188L and M230L also lead to resistance to doravirine. So I think this is useful and just helps us to better understand doravirine resistance patterns. It's, a lot more than the included in the doravirine islatravir study, and interesting to see this sort of like risk in the first year, and will be helpful to understand if that has like a mechanistic meaning or something to do with the barrier or just the adherence of the patients during that time period in those particular individuals. But again, low rate, small number of individuals who've been analyzed, but sort of coalescing around a couple of defined resistance mutations. So then there was this study, which is I think it's D squared Arling or Darling, I'm not sure. But this is use of upfront dolutegravir and 3-TC. So we talked about a similar study that Charlotte Roll had done and published in AIDS, where the idea is in a rapid start setting where they use dolutegravir 3-TC in rapid start. So this is a slightly different. So it's open label non-inferiority. They enrolled treatment naive individuals without resistance testing, although they did confirm that they didn't have Hep B or Hep C. And their comparator of 3-TC or FTC with TDF with dolutegravir. So it's either triple drug therapy or dual therapy with dolutegravir 3-TC. And they had a planned primary endpoint at week 48, but the analysis presented at the meeting was actually an interim analysis at week 24. So the results, virologic success rates of less than 50 copies per mil were similar in this study, and weight gain was 2 kilos in the dolutegravir 3-TC versus nothing in the dolutegravir TDF XTC. So I'll just pause on the weight gain issue because this is a theme that'll come out a little bit later too. I think we may have all been fooled in that I think that the emerging data really does continue to support the idea that TDF, and in particular in combination with efavirenz, is actually weight suppressive as compared to other regimens being so much weight promoting, at least in some people. And that would be suggested by these data here and other data that we'll touch on later. But outside of that, just sort of reflecting on this study overall, I mean, I continue to wonder if there really is a role for upfront dolutegravir 3-TC. So this now is a sort of comparative trial of two strategies prospectively enrolling. And then we have the single arm just initiate dolutegravir 3-TC at rapid start that was published in AIDS and previously presented by Charlotte Roll. And I think I still would only do this if I was totally pressed to by evolving renal function, because to me the risks of TDF or TAF are low enough that I don't feel compelled to do this without confirming. And then we'll come a little bit later to a study that looked at the risk of a prevalent, a history, not prevalent, but historical M184V. I don't know if other people feel differently, that you would like to start using dolutegravir 3-TC up front. But in the Roll study published in AIDS, what they did was they followed up, and if people had Hep B or resistance, then they switched them. And nobody had an adverse consequence of being on a regimen that's imperfect for that period of time. But this study was a bit different.
Eileen, I've used it only in patients with like those super low viral load, like the viral 200, 300, just because I feel like they don't need much. But I have used it as a upfront in those patients before.
Yeah, no, David, that's actually a great point. Like for elite controllers that you're starting on treatment where they're actually probably too low to get or not elite controllers, but viral suppressors who are in the thousands range or 1,000 range or lower. I love it for that indication. And that's a good point for people with very low viral loads. Okay, and then I'll also just present this data from the advanced trial because I thought this was actually quite interesting. So this is looking at the rate of resuppression with modern regimens. So this was presented by, I think it was Andrew Hill from the advanced trial group. So the advanced trial was done in South Africa, enrolled treatment naive individuals who were non-pregnant and did not have TB, 61% of whom were female. CD4 counts were in the median 300s and 30% had viral loads greater than 100,000. It enrolled 1,000 participants and randomized them 1-to-1-to-1 to dolutegravir FTAF, dolutegravir FTDF and efavirenz FTDF, and then followed them for 192 weeks. And the question that they were trying to answer here is, should treatment regimens be changed when there is viremia in the context of using dolutegravir? And this is important because as the author highlighted, there's approximately 20 million people currently on TLD, which is tenofovir, lamivudine, dolutegravir globally. So understanding our approach to viremia on this regimen and what the safe, next steps are to achieve suppression is actually really important. In the advanced trial, unlike other standard drug trials, individuals who had viremia were counseled and restarted on the regimens that they were on, as opposed to changing to a PI-based therapy, which can be a reflexive response to virologic failure in resource-limited settings. So here's the WHO table about what to do in global settings with people who develop viremia. And it's just notable here that if you have a viral load greater than 1,000 and you're on an NNRTI-based regimen, you're supposed to switch at that point. And the question is, that's what we've done with efavirenz. What should we do with dolutegravir? With efavirenz being the global first line, and what should we do with dolutegravir now that there's 20 million people on it? So their definitions for this study were viral suppression to less than 50 copies. Virologic failure is defined at greater than 1,000 copies at more than 24 weeks after randomization, so allowing people to get to viral suppression. And resuppression was defined at re-achieving a viral load of less than 50 after you'd had it, lost it, and then get it again. So here's their rates of virologic failure overall in the study. So very low, but small rates of virologic failure in both the dolutegravir arm here in blue and the efavirenz arm here in yellow. And so with their approach of counseling and restart, what do we see among that low rate, that small proportion of the population who did have virologic failure? And so what you can see here is that the blue line here is being dolutegravir. Resuppression with counseling and restarting the regimen was 88% at 24 weeks and 95% at 48 weeks. So very high rates of resuppression if you just tell someone to take their medicines and they start them again. And efavirenz, apologies for another typo, 46% resuppression at 24 weeks and 66% resuppression at 48 weeks. So I think that overall, these data are supportive of the fact that in high barrier regimens like dolutegravir and previously with darunavir, counseling and reinitiation of a regimen that has failed will likely achieve resuppression in the absence of a few particular scenarios, like someone who is taking their medications every other day and has been viremic with subtherapeutic drug for a very long time, but very frequently people who have failed, usually for more prolonged non-adherence, or have a small rise in viral load associated with a brief period of non-adherence, will achieve resuppression with restarting their dolutegravir-based regimen. So this is overall very reassuring and will inform global policy, I think, in how we approach restarting regimens after virologic failure. So then the other study on dolutegravir 3TC that I did want to mention was presented by Dr. Gary Blick, who has a nonprofit HIV treatment facility and also has been referred to himself like repeatedly as a dinosaur, but has been treating HIV for a very long time. And so what he said was, the current indications for dolutegravir 3TC are very narrow. So as a switch therapeutic, it was studied for people with no history of virologic failure, and that just doesn't account for many of his patients in his long-term practice. So he wanted to look at whether dual therapy in a heavily treatment-experienced population with a history of virologic failure, so definitely excluded from the registrational trials, would be effective. So enrolled adults with HIV greater than 18 years of age, HIV less than 50 for greater than or equal to 6 months, any stable ART regimen, any regimen at all, for more than 6 months, definite history of prior virologic failure, and greater than 2 prior ART regimens with at least one of the following: either an HIV viral load of, that should be greater than 50 copies per mil, a confirmed rebound to greater than 200 copies per mil, and documented phenotypic or genotypic resistance. No exclusions for prior exposure to integrase inhibitors, any CD4 count, no prior nucleoside reverse transcriptase inhibitor mutation exclusions. And they did a baseline proviral sequencing where they reportedly had a sensitivity to about 10%. So there are some assays that reportedly have sensitivities to 5%. As we've discussed before, unclear whether what those thresholds mean in terms of their ability to detect mutations, but that's what they did in the study. They did the proviral genotype, but they did not look at it. So just collected it. So how did they do this? This is prospective and open label for 96 weeks with a 144-week extension. They enrolled 2 groups, and they were basically just people who presented to his practice who met these criteria and were offered enrollment in the study. He enrolled 50 who had a prior M184V and 50 who did not have a prior M184V to specifically test the question of whether that historical M184V was going to affect the efficacy of this regimen. And the primary endpoint was HIV less than 50 at week 48 and 96. So a few things: the prior M184V resistance mutation group here in the purple column, the median age was 61. The median time since HIV diagnosis was 28 years. The median ART duration was 24 years, and median prior ART regimens was 9. The median duration of HIV viral suppression, although the inclusion criteria was 6 months or greater, was 12.8 years. So this is like actually similar to some of our patients who've just had HIV for a very long time, have been on many, many different ART regimens, but have been suppressed stably for a long period of time. In comparison to the ones who did not have the M184, the other 50, they were a little bit younger, age of 55, only had HIV only for 15 years, had a median ART duration of 15 years and a median duration of HIV viral suppression of 8.9 years. But in both groups, very long viral suppression and multiple different regimens in the past. So the median prior ART and the no historical resistance was 4. Because again, everybody had to have something defined as virologic failure. So the first thing I'll just say is that I was very excited about this study up until this slide, because 50% of the people in this study in both groups had been on dolutegravir or abacavir 3TC at the time of enrollment, which, since I have previously revealed my anti-abacavir bias, means to me that they've basically been on essentially dolutegravir 3TC for a while. So I am not surprised that 1/2 of these 100 participants continued to maintain suppression after switch to dolutegravir 3TC. So that to me was a little bit disappointing. And in theory, like if you have a historical M184V, like that should give you pause about Triumeq as in the dolutegravir abacavir 3TC, in the same way it gives you pause about dolutegravir 3TC. But setting that aside, the one other thing I thought was very notable in this table was they did report the results of their proviral genotyping, and 37% of those who had a known M184V, so documented previously, were detected on their proviral genotyping. So that means that if I know you have it, I have slightly better than a 1 in 3 chance of detecting it on this proviral genotyping assay that they did. And again, this sort of feeds back into the conversations we've had about how to use proviral genotyping, given that we know that 80% from the work of the siliconos, that 80% of the DNA that's there is unlikely to be replication competent. That means 80% of what you're sampling is not going to produce an infectious virus. So if you detect something, there's a paper from John Lee and others that suggest that the detected mutations are more frequently found on non-replication competent viruses, so ones we didn't need to worry about. But that said, I've seen clinically, as have others, the cases where you know someone has mutations and they do not show up on that assay. So how we use that assay, I think, will continue to evolve over the course of the next few years, but just another data point to add, and in particular, a data point from a very heavily treatment experienced population. So what did they see? They saw that it worked. There were no confirmed virologic failures, no significant differences in viral blips, no significant differences in rate of being undetectable on the assay, not just less than assay. And at their primary, in their intention to treat analyses, they saw equivalent rates of virologic suppression in the high 80s to 90s, either with or without a historical M184V. So the presenter actually was like borderline euphoric about the results, and in particular for thinking about the potential financial impact on a global level. Like as I've mentioned earlier, the other presentation highlighting that there's like 20 million people who are taking tenofovir, lamivudine, dolutegravir. If they could just take lamivudine, dolutegravir there would be substantial savings is one argument. And the other, and even in the setting in the US, if all you needed was dolutegravir 3TC, that would potentially lead to cost savings, although I'm not clear exactly what that would look like given co-formulation and patenting and other things. I don't know enough about the health economics of that to really comment. But I have to say that this is a study of 100 people, 50 of whom already were on what is like classically considered to be a suboptimal regimen based on their known resistance history, and the fact that they maintain their suppression after having had suppression for 12 years just is not, to me, necessarily equivalent to every one of those 20 million people who are currently on TLD. So I'll just pause there. So I think and see if people have some comments about the emergence role of dolutegravir 3TC. And for example, whether you think if you had dolutegravir 3TC, like, so taking those three sort of studies together, the dolutegravir 3TC initiation, the resuppression on dolutegravir plus FTC TLD, so dolutegravir with tenofovir in there, and then now this study to suggest that dolutegravir 3TC works quite well. What do you think would you think that if we did the resuppression study with only dolutegravir 3TC that would work also, or do you need the tenofovir in that setting? I'll see if there's anybody I can harass. I did see Chris Hoffman, and since I've been like, extemporaneously commenting on global stuff, if he wanted to make an actually informed comment, that would be great. But
hey, Eileen. Yeah, I don't know that I have any informed comment to make. I totally agree with your comments about this study. And it's also, I missed what you said their definition of virologic success was at 48 weeks, but it seems like these people were suppressed for 12 years and then 5 in each group were not. Was it that they just didn't have testing, or were they truly viremic at that point?
oh, you mean at the ones who at the end were, so it was less than 50.
Failures.
Yeah. So he actually made this comment that at 100 weeks, it was 100% success. Everybody was suppressed. So they were like less than 50. And I don't think they were changing people for quotes failure. So he did comment that at 100 weeks, which was not their defined endpoint, they had 100% viral suppression.
I mean, I think lots of people could have comments that would be more informed than my comments, but I would not switch people to dolutegravir and 3TC in the global context who are failing or who are not failing. But that's my bias, that the tenofovir has some real value.
Yeah, no, I mean, I think there was just a patient on Polk who I think sees Larry as an outpatient, and we had sort of dug through the history because he had evolving renal function to see whether or not he would do okay in dolutegravir 3TC, was currently on BIC/FTAF. And I do think this does help me a little bit. Like, I think that person who fits this characteristics had been suppressed for a very long time, had, maybe a question of failure that might have induced an M184 at some point, but not even documented. I think probably he would do just fine on dolutegravir 3TC. And if there were, as the GFR continues to drop, that might be a consideration. As far as like changing the whole world, I think maybe not so much yet. The one other thing I did want to just sort of go through briefly, and then we'll have some time for discussion at the end. So a couple of abstracts looking at weight, as we all know, a major issue. So there was the DEFINE study that switched people from an INSTI to darunavir Cobi plus FTAF, or kept them on their INSTI-based regimen, and that showed no impact on weight, not at all. Kind of depressing. The doravirine and islatravir switch studies, there was an analysis by Grace McComsey looking at all of the switch studies that had been done, and weight changes were similar with change to DOR-ISL as with BIC/FTAF or INSTI regimens from a baseline ART not containing efavirenz TDF. So meaning whatever you change to, the weight gain was about the same, whether you change to BIC/FTAF or another INSTI plus 2 NRTIs, depending on the study. The weight was about the same as Dor-Issel, and that's for the switch context. As I already told you earlier, the initiation context, there was no difference between Dor-Issel and BIC-FTAF. In the switch context, the notable thing was that if at baseline you were on efavirenz, FTD, TDF, you gained a lot more weight when you switched. Again, pointing back to this idea that tenofovir disproxil plus minus efavirenz may in fact be weight suppressive. In another study by Charlotte Page-Roll, she showed that there was some very, very small differences between regimen switches with weight gain. But the biggest difference was a referral to a wellness clinic, which was associated with something that was like literally almost like a log higher weight loss. I mean, like it was like 3 kilos of weight loss and the people were referred to the wellness clinic versus like 0.7 versus 0.3, depending on your regimen, kilo weight loss. So I guess we need a wellness clinic. And then there was also one study looking at the use of GLP receptor agonists in individuals with HIV and diabetes as opposed to just diabetes alone. And it did actually show greater weight loss in the HIV plus diabetes context. It was significantly larger. The matching of the study wasn't totally clear to me, but it did suggest that there might be sort of like an additional synergistic benefit to GLP agonists in the setting of HIV plus diabetes versus diabetes alone. So I will stop there. Those were the main things that I had put out to discuss, and maybe I'll stop sharing so that maybe other people will comment. I'm happy to go back to any of these studies. I know that I talk really fast, but if I think the summaries for me were that, you know, we're getting a little bit more data about dual therapeutic regimens. There is likely to be something from islatravir in the future, and exactly the niche that will fit into, whether it might be in drug resistance, as Joyce suggested, or in particular context of comorbid conditions. Not totally clear yet. In terms of weight, I think TDF is weight suppressive. Whether or not that means we want to put people back on it is a question. That effect is biggest if it's with efavirenz, which we're probably not going back to. So again, whether switching to TDF would help, we don't know yet, till the current ACTG trial may help to answer that. That is, I think, still enrolling here. Charlie, you can correct me. So remember to refer patients to that. And then I'll stop there and see if other people had highlights that I missed.
Hi, Eileen. Thank you for the great overview. A couple of things. One thing for me is actually the dolutegravir 3TC. It, for me, gave me just a little bit more evidence to feel more comfortable with it than I used to be. So that's how I felt. And then the islatravir is intriguing for me just because mainly because of, for my patients with multi-drug resistant virus, and then difficulty swallowing pills, difficulties with pill size. I would love all of the options. Often these people are on darunavir, covistat, and that's a big pill. And if they can't take the big pill, they're taking 2 pills. And then there's still some like nausea and GI side effects with that. So those were, for me, like the ones that I'm just thinking about in terms of like how it could impact my clinical practice. But thank you for the really nice overview.
Yeah, and then of course reprieve, which I think.
Oh yeah, and I'm talking to all of my patients about that at this point, frankly. And then, you know, just being more aggressive for the people for whom it's, you know, clearly indicated, and as sort of, you know, people with diabetes, just having more confidence and being more aggressive about statin therapy. And I was thinking about one other thing. Oh, I just wanted to mention, just with our metrics, our clinic is the best of all the ambulatory clinics in terms of statin therapy for patients. And I feel like I'm wondering how much just reprieve has been part of that, and just our awareness of the higher risk of cardiovascular, adverse cardiovascular events has played into it. But we do a really nice job of that for people for whom it's clearly indicated.
And I think I'd encourage people to think about patients who they have questions about it for, because like, for example, I just had a patient in the office the other day. He's like a man in his 50s. His lipid profile is beautiful. He's absolutely petrified of getting diabetes, always wanting an A1C, which is like 4. And we know that statin therapy is associated with a slightly higher risk of developing diabetes. I told him about the Reprieve study. I told him that he was like a candidate to take it. And he was like, no. And I was like, oh, I do want, like, this is kind of the person. And yet also, I'll be really interested to see what Todd would say in those settings and how he would counsel people. And so if people have little vignettes like that, we can sort of give him some tough clinical cases and how he would counsel about the use of statins.
Thanks for the nice overview.
Hey, Matthew.
Hi, Eileen. Thanks so much. With the conversations around efavirenz being weight suppressive potentially, what's the sort of the mood around switching people from integrase inhibitors back? I mean, it feels a little aggressive in many ways, but I just wondered what your thoughts were. Were there any data from the conference?
So I think that's a great question, Matthew. And so actually, I think it was I think it was AIDS or else it was CROI, but there was a session where people discussed whether or not all of these studies that were comparing dolutegravir to efavirenz should continue, right? Whether we have moved past efavirenz, and so doing studies like the ADVANCE trial, which was done years ago, but like doing more modern studies where you can have a comparator arm that's an NRTI, like efavirenz that has known CNS toxicities is that are significant to patients is still appropriate. And actually, there was a woman investigator who basically said this weight gain is unmanageable for some people, and there are some people who still prefer efavirenz as their first line agent. And keeping in mind that like the median weight gain in I think ADVANCE at the 96-week endpoint was like 18 to 20 kilos in women who were in the dolutegravir FTAF arm, as compared to something like 8 kilos. So a 10 kilogram difference in weight gain based on that regimen. So I think that's the question. And I don't think there's much appetite for efavirenz as first line because of all the other lower virologic efficacy things that we see. And even that analysis of the resuppression in ADVANCE, right? A maximum of 46% resuppression if you have virologic failure in efavirenz, whereas you're, up above 88 to 90% in dolutegravir resuppression. It's hard to argue that that's the pathway forward. I think the question of whether, if we can understand mechanisms here, and if there's a way to approach therapy more rationally in terms of who's at risk, who's at greatest risk of this weight gain, and how to temper that, I think that would be probably the most useful thing. And then we'll see if the switch study works. I mean, the switch scenario, like once you've gained weight, whether or not you lose weight is kind of like, I mean, that's hard, right? Losing weight is hard. And so I don't know. I don't hear a lot of enthusiasm for going back to ATRIPLA, but that would be the combination. That would be the lowest weight. And the other piece of data, Ethel put this beautiful paper in about weight change after starting efavirenz and versus dolutegravir. And the other piece of data is from pregnancy, where in pregnancy, we know that women with HIV don't achieve recommended weight gain, and those on efavirenz TDF have the lowest weight gain, and those on dolutegravir TAF have the highest weight gain, still lower than what you should gain. Again, arguing that there's a weight suppression as opposed to a weight enhancement. So I don't know. I think this will be a question as we move forward.
Thank you, Eileen.
Well, it's 12:59. Please feel free to email me if you have questions about anything I said too quickly. And thanks to everybody for joining, and have a great day.